Have you ever felt that nagging discomfort in your stomach? Or maybe wondered why some foods just seem to, I don't know, declare war on your digestive system? Well, today, we're embarking on a deep dive into the often misunderstood world of gastric disorders. It's a really fascinating area, actually. You've got everything from microscopic bacteria to, well, your own immune system playing these surprising roles. Our mission to kind of unravel the common causes, maybe some surprising symptoms, and definitely the latest insights into how we understand and manage conditions affecting your stomach and your upper digestive system. We've gathered a lot of medical insights to guide us, so let's get you well informed.
Absolutely. And what's truly fascinating here, I think, is how seemingly really different factors, a tiny bacterium, maybe the medications we take, stress, or even how our own body reacts, they can all lead to similar symptoms in the stomach. Understanding these different root causes is just, well, it's absolutely critical for effective treatment and for long-term health, really.
Wow.
The stomach, with its incredibly strong acids, it's a marvel of resilience. It truly is. But it's also surprisingly vulnerable sometimes.
That's a great starting point. So let's begin with a name many people have probably heard but maybe don't fully grasp, H. pylori. What exactly is this bacterium and why is it such a significant player in stomach health?
Right, H. pylori, it's this unique spiral-shaped bacterium. And what's really astonishing about it, scientifically speaking, is its ability to not just survive, but actually thrive in the stomach's superacidic environment. That's quite a feat. It's incredibly common globally. Although, interestingly, it's less common in children in North America, maybe only about 1% prevalence there. But if we connect this to the bigger picture, H. pylori isn't just, some minor bug. It's a major cause of gastritis. It's the inflammation of the stomach lining we mentioned, and also peptic ulcer disease. But here's the really crucial part. It significantly increases the risk of gastric adenocarcinoma, which is a specific type of stomach cancer, and even a certain kind of gastric lymphoma.
Wow. Okay, that's pretty serious. It definitely sounds like this little organism really punches above its weight, doesn't it?
Yeah.
How exactly does it spread? And what kind of trouble does it actually cause once it takes hold in your stomach?
Yeah. It's typically transmitted through, oral, or fecal-oral routes, often from things like contaminated food or water. We even see instances sometimes where improperly disinfected endoscopes can, unfortunately, transmit it between patients. Once it gets inside, its effects can vary a bit, depending on where exactly it decides to set up shop in the stomach. So if it primarily colonizes the lower part, the antrum, it can actually lead to increased acid production. And that makes duodenal ulcers in the first part of the small intestine, much more likely. But conversely, if it settles mostly in the main body of the stomach, it can cause decreased acid, and a condition called gastric atrophy, which is like a thinning of the stomach lining. And this specific pattern, the body-predominant one, is more closely linked with gastric ulcers in the stomach itself, and critically, that increased risk of stomach cancer we talked about.
Right. That makes sense. Different locations, different problems.
Right.
So given its potential for causing all this trouble, how do doctors actually go about finding this sneaky bacterium?
Good question. Diagnosis can be done using either non-invasive or invasive methods. On the non-invasive side, we've got the urea breath test. That's where you drink a special solution containing urea. If H. pylori is present, it has an enzyme that breaks this urea down, releasing carbon dioxide, and we can measure that extra CO2 in your breath. Pretty clever, actually. Another excellent non-invasive option is the stool antigen test. This one directly detects H. pylori proteins, or antigens, in a stool sample. Now, a really key point to remember for both of these tests is that recent antibiotic use, or taking those common acid-suppressing medications called proton pump inhibitors, or PPIs, they can sometimes lead to false negative results.
Ah, okay, so it might look like the infection isn't there, even if it actually is.
Exactly. It can make it seem like you're clear when you're not. So timing is important, and your doctor needs to know about recent medications.
And for a more direct look, I'm guessing there's an endoscopic option too, like going in with a camera.
Precisely. Invasive diagnosis typically involves an upper endoscopy. A thin tube with a camera goes down into the stomach to directly visualize the lining. During this procedure, the doctor can take small tissue samples called biopsies. These biopsies can then be used for a couple of things. One is a rapid urese test right there, which quickly confirms the presence of the bacteria's enzyme. Or they can be sent to the lab for histology. That's where they're examined under a microscope to see the bacteria and any inflammation.
Great. That raises the next critical question then. Once H. pylori is identified, what's the usual game plan? How do you get rid of it?
Right, eradication is the goal. The standard approach nowadays is often called quadruple therapy. Doesn't sound very friendly, does it? But it usually involves a proton pump inhibitor, one of those PPIs, to reduce acid, along with 2 different antibiotics. Commonly used ones are amoxicillin, metronidazole, or clarithromycin. And sometimes a fourth agent, bismuth subsalicylate, is added. That's the stuff in Pepto-Bismol, actually. The treatment course is generally for 14 days.
13 days, okay. Are there any challenges with that treatment?
Yes, one of the growing challenges, unfortunately, is antibiotic resistance, especially resistance to clarithromycin, which has been a workhorse antibiotic for this. So doctors really need to be aware of local resistance patterns in their area when they're choosing the most effective combination of antibiotics for you. It's becoming more personalized.
That makes sense. You need the right tools for the job, especially if the bug is fighting back. Okay, so if H. pylori is one major player in stomach distress, what about when the stomach lining itself just becomes inflamed, maybe without that specific bacterial culprit? That brings us to gastritis, right? What exactly is gastritis, and what else can cause it besides H. pylori?
Yeah, gastritis is quite simply inflammation of the gastric mucosa. That's the inner lining of the stomach. It can come on suddenly, which we call acute gastritis, or it can be a more long-lasting chronic issue. And you're right, besides H. pylori, other common culprits include the regular use of nonsteroidal anti-inflammatory drugs. NSAIDs, think things like ibuprofen, naproxen, very common painkillers. Also, excessive alcohol consumption can definitely irritate the lining. And interestingly, certain autoimmune reactions, where your body's own immune system mistakenly attacks the stomach cells.
Okay, and our sources seem to break down gastritis into a few distinct types based on what's happening. Let's start with erosive gastritis. What makes that type different?
Erosive gastritis, as the name suggests, involves actual erosion or wearing away of that stomach lining. You can think of it like small scrapes or sores developing on the surface. A key feature here is that it often leads to bleeding because those erosions can damage small blood vessels, common causes. Well, severe stress is a big one, especially in patients who are critically ill in the hospital. That's why they often receive preventative treatment with acid suppressants. Also, NSAID use, again, alcohol abuse, sometimes radiation therapy to the area, certain infections besides H. pylori, direct trauma, or it can even be a manifestation of systemic conditions like Crohn's disease affecting the stomach.
So if someone has erosive gastritis, how would they even know? You said it can cause bleeding, but can it be subtle otherwise?
It absolutely can be subtle. Sometimes it's completely asymptomatic, meaning you feel nothing at all. But if symptoms do appear, they might include things like indigestion, maybe some nausea or vomiting, and most concerningly, signs of gastrointestinal bleeding. This might show up as vomiting blood, we call that hematemesis, or passing those dark, tarry stools, which is called melena, that's from digested blood. Sometimes, believe it or not, bleeding is the very first sign that something's wrong. Treatment typically focuses on supportive care, trying to remove or stop the cause if possible, like stopping NSAIDs and using those acid-suppressing medications, the PPIs or maybe H2 blockers, to give the lining a chance to heal.
Okay, then there's the other category, non-erosive gastritis. What's the key difference there? What's happening more on a microscopic level?
Right. So unlike erosive gastritis, with non-erosive gastritis, you don't typically see those significant visible erosions or sores when looking with an endoscope. Instead, the changes are mainly seen under the microscope in those biopsy samples. It's primarily caused by chronic H. pylori infection. Microscopically, we can see various stages of inflammation. It might start as superficial gastritis, just mild inflammation near the surface. Then it can progress to deep gastritis, which is more extensive inflammation throughout the lining. And then there's a condition called gastric atrophy. This is where there's actually a loss of the specialized glands in the stomach lining. And this loss is significant because those glands are what produce stomach acid and also something called intrinsic factor, which is absolutely crucial for absorbing certain nutrients, particularly vitamin B12.
Ah, okay. And I remember reading about something called metaplasia in relation to this non-erosive type. That sounded important. Can you explain that?
Yes, absolutely. Metaplasia is a very important concept here. In chronic non-erosive gastritis, particularly the kind associated with H. pylori or autoimmune issues, the stomach lining can undergo this transformation called metaplasia. Essentially, the normal stomach cells get replaced by cells that look more like they belong in the intestines. We call this intestinal metaplasia. And this is a critical point because intestinal metaplasia is considered a precancerous condition. It significantly increases the long-term risk of developing stomach cancer, that gastric adenocarcinoma we mentioned earlier. Often, though, non-erosive gastritis itself can be surprisingly asymptomatic or maybe just cause some mild indigestion, some dyspepsia. So treatment really focuses on eradicating H. pylori if it's present to stop the ongoing inflammation, and sometimes using acid suppression for symptom relief, but the monitoring for metaplasia becomes really key.
And this leads us to something really fascinating and maybe, like you said, a bit unsettling. The idea that sometimes your own body can be the cause. Tell us about this autoimmune metaplastic atrophic gastritis, or AM. That's a mouthful.
It is a mouthful, AMAG. It's a powerful example of autoimmunity, where the immune system mistakenly turns against the body's own tissues. In AMAG, which is often inherited, the body's immune system specifically attacks its own parietal cells. Remember, those are the crucial cells in the stomach lining that produce both stomach acid and intrinsic factor. So you get this cascade effect. The destruction of parietal cells leads to drastically reduced stomach acid, a condition called hypochlorhydria or even echlorhydria, meaning no acid. And perhaps more critically, the loss of intrinsic factor leads to a severe difficulty in absorbing vitamin B12 from your diet. This, in turn, eventually causes pernicious anemia, which is a serious type of anemia resulting from B12 deficiency.
Wow, so it's like a chain reaction starting with the immune system. Are there other long-term risks specifically linked to an AMAG?
Absolutely. Besides the pernicious anemia, patients with AMAG face a significantly increased risk, about a threefold higher risk of developing gastric adenocarcinoma. They also have an increased risk of developing other types of stomach growths called neuroendocrine tumors. Diagnosis usually involves that endoscopy with biopsies to look for the characteristic atrophy and inflammation, and sometimes blood tests can detect antibodies against parietal cells or intrinsic factor. For treatment, since the body can no longer make intrinsic factor to absorb B12 from food, the primary approach is lifelong vitamin B12 supplementation, usually given through injections to bypass the digestive system altogether. And really importantly, given that elevated cancer risk, regular endoscopic surveillance, having endoscopies done periodically, is crucial, especially if metaplasia is found or if there's a family history of gastric cancer.
Okay, that really highlights how complex these interactions can be. Now let's shift focus slightly to something many people immediately think of when they hear stomach issues. Peptic ulcers. What exactly is an ulcer, technically speaking, and why do they seem to cause so much persistent trouble?
Right, ulcers are definitely what come to mind for many people. A peptic ulcer is essentially an erosion, but it's a deeper one. It's a sore or a break in the lining of either the stomach itself, that's a gastric ulcer, or the duodenum, which is the very first part of the small intestine right after the stomach, that's a duodenal ulcer. The key difference from just gastritis or erosions is that an ulcer penetrates deeper, going through a protective layer called the muscularis mucosa. It's a more significant breach in the wall. And if we connect this back, ulcers are often the end result, the culmination of significant damage to that protective stomach lining. And the main culprits causing this damage? Well, it's those same two we keep mentioning. H. pylori infection that causes over half of all duodenal ulcers, and the use of NSAIDs, which contribute to maybe 30 to 50% of all peptic ulcers.
So what does that classic ulcer pain actually feel like? We hear about burning pain, and are there other symptoms people should be aware of?
Yes, the classic symptom, though not everyone experiences it this way, is a burning or gnawing pain in the upper abdomen, kind of between the breastbone and the belly button, the epigastric region. Often, particularly with duodenal ulcers, this pain might actually be relieved temporarily by eating food or taking antacids because they buffer the acid. Gastric ulcer pain might sometimes worsen with eating. Other symptoms can definitely include nausea, sometimes vomiting, and occasionally unexplained weight loss. And it's really important to clarify a common misconception here. While stress and certain spicy or acidic foods can certainly worsen ulcer symptoms and make you feel more uncomfortable, they are generally not considered the primary causes of the ulcer itself. The real drivers are usually that H. pylori bacterium or the damage from NSAID medications. However, one lifestyle factor that does significantly increase the risk of developing ulcers and also impairs their healing is smoking.
Okay, that's a crucial clarification about stress and diet. Now, beyond just the pain, which can be bad enough, what's really concerning are the potential complications if an ulcer isn't treated properly, right? What can happen then?
Yes, this is where ulcers can become truly dangerous. There are three major, potentially life-threatening complications we worry about. The most common one by far is hemorrhage, which just means bleeding. The ulcer erodes into a blood vessel in the stomach or duodenal wall. This can cause you to vomit blood, which might look bright red, or sometimes like coffee grounds if it's been sitting in the stomach acid. Or it can lead to passing those black, tarry stools melena as the blood gets digested on its way through. Significant bleeding is a medical emergency.
Okay, bleeding is number one.
Yeah.
What are the other two major ones?
The second major complication is penetration, or perforation. This is even more dramatic. Penetration is when the ulcer erodes through the stomach or duodenal wall and into an adjacent organ, like the pancreas. Perforation is when it erodes completely through the wall and creates a hole, spilling stomach contents directly into the abdominal cavity. This causes sudden, severe, and diffuse abdominal pain. It's often described as the worst pain someone's ever felt. It's an absolute surgical emergency. A key sign doctors look for on an X-ray or CT scan is free air under the diaphragm, air that has escaped from the digestive tract.
Wow, that sounds incredibly serious.
Yeah.
And the third major complication?
The third one is gastric outlet obstruction. This tends to happen more with chronic, long-standing ulcers, often near the exit of the stomach, the pylorus. Through repeated cycles of inflammation, ulceration, and scarring, the opening from the stomach into the small intestine can become narrowed or blocked. So food can't easily pass through. Patients often experience recurrent vomiting, sometimes of food eaten hours or even days before. They feel full very quickly after eating just a small amount that's early satiety and can have significant weight loss as a result.
Okay, those complications sound quite frightening. So for someone experiencing symptoms that might suggest an ulcer, how does the diagnosis typically proceed, and what's the general path to treatment, assuming none of those emergencies have happened yet?
Right. For uncomplicated suspected ulcers, the primary diagnostic tool is usually an upper endoscopy again. It allows the clinician to directly see the ulcer, note its size and exact location, and importantly, take biopsies. Biopsies are crucial, not just to test for H. pylori, but also, especially for gastric ulcers, to rule out malignancy, as some stomach cancers can look like ulcers initially. As for treatment, the mainstays are, first, powerful acid suppression to allow the ulcer to heal. Proton pump inhibitors, those PPIs, are really the gold standard here, usually prescribed for several weeks. Second, if H. pylori infection is found, eradicating it with that antibiotic combination therapy is absolutely critical to prevent the ulcer from coming back. And third, if NSAIDs are identified as the cause, stopping them is paramount. If NSAIDs absolutely must be continued for another medical reason, then long-term PPI therapy is often needed for protection. And of course, for any of those acute complications we just discussed, severe bleeding, perforation, obstruction, emergency interventions, often including surgery, may be necessary.
That makes sense. Attack the cause, reduce the acid, let it heal. Okay, since stomach acid is such a central player in, well, pretty much all of these conditions, gastritis, ulcers, even helping H. pylori indirectly, let's talk a bit more about how we actually manage it. Our sources reveal quite a few different types of medications. Can you walk us through the main approaches to controlling stomach acid?
Absolutely. Understanding these medications is really about understanding how acid is made and how we can interrupt that process or protect the lining from it. So briefly, stomach acid is produced by those specialized parietal cells we mentioned. They're stimulated by various chemical signals, including a hormone called gastrin, histamine, and a neurotransmitter called acetylcholine. The first major class of drugs, and the most powerful, are the proton pump inhibitors, or PPIs. These are incredibly effective because they directly block the final step in acid secretion. They inhibit an enzyme called H+, KK plus ATPase, often just called the proton pump, which is literally the pump that pushes acid protons into the stomach. Think of them as shutting down the main acid factory faucet. Common examples you might recognize are names like omeprazole, lansoprazole, pantoprazole, and so on. PPIs are widely used for healing ulcers, usually for about 6 to 12 weeks, and they're a cornerstone of H. pylori eradication therapy because reducing acid helps the antibiotics work better.
Okay, PPIs are the heavy hitters. How do they compare to the H2 blockers? Those seem to work differently.
That's a great distinction. Histamine 2 receptor antagonists, or H2 blockers, like famotidine or cimetidine, though cimetidine is used less now due to interactions, work a step earlier in the process. They specifically block the histamine receptors on those parietal cells. Since histamine is one of the key signals telling the cells to make acid, blocking its receptor reduces acid production. They are effective, especially for milder symptoms or nighttime acid control, but generally they provide a less potent and shorter duration of acid suppression compared to the PPIs. Then, of course, you have the simplest approach, antacids.
Right, like Tums or Rolaids.
Exactly. Things like calcium carbonate, magnesium hydroxide, aluminum hydroxide. These provide very quick relief because they work by directly neutralizing the acid that's already present in the stomach. They act like a chemical buffer. However, their effect is usually quite short-lived, maybe an hour or two, and they don't do anything to reduce ongoing acid production. Plus, they can have side effects. Magnesium-containing ones can cause diarrhea, while aluminum or calcium ones might cause constipation.
So beyond just turning down the acid tap or neutralizing what's there, are there any medications that work differently, maybe by actually helping to protect the stomach lining itself?
Yes, there are a few other types of protective agents, which is an interesting approach. One class includes prostaglandins, with misoprostol being the main example. Prostaglandins are natural substances that help protect the stomach lining by increasing mucus and bicarbonate production, and they also have a mild effect on reducing acid. Misoprostol is particularly useful for preventing and treating ulcers specifically caused by NSAID use, as NSAIDs deplete natural prostaglandins. But a crucial point is that it absolutely cannot be used during pregnancy because it can induce labor. Another interesting one is sucralfate. This medication doesn't really affect acid much at all. Instead, in the acidic environment of the stomach, it forms a kind of sticky, paste-like substance that selectively binds to ulcers and erosions. It essentially forms a physical barrier over the damaged area, protecting it from further injury by acid and digestive enzymes, allowing it to heal underneath.
Like a Band-Aid for the ulcer.
Exactly, sort of like a liquid Band-Aid on the inside. And then, just to mention them, there's a newer class of potent acid suppressants emerging called potassium-competitive acid inhibitors, or PCAs. Vonoprazan is an example available in some regions. These drugs also inhibit the proton pump, but through a slightly different mechanism that leads to very rapid, profound, and sustained acid inhibition. They're showing promise for difficult-to-treat erosive esophagitis and are also being incorporated into some newer H. pylori eradication regimens.
Wow, quite an arsenal of options then, targeting different parts of the problem. We've certainly covered a huge amount of ground today, navigating the intricate world of gastric health. It's really clear, isn't it, that our stomachs are incredibly complex ecosystems. And these issues, gastritis, ulcers, H. pylori, they aren't really isolated events. They seem deeply interconnected.
Indeed they are. And I think the really key takeaway here for everyone listening is that symptoms like stomach pain, indigestion, heartburn, while they're incredibly common, they shouldn't just be ignored or constantly self-treated without understanding the cause. They can absolutely be signs of very treatable conditions like H. pylori or NSAID-induced damage, but they can also be important indicators for longer-term health considerations, like that underlying risk of cancer associated with atrophy or metaplasia, which might require ongoing surveillance. The body often gives us these clues, these signals, and it's really important to pay attention and get them properly evaluated.
Absolutely. And understanding these mechanisms, the potential causes, and the treatments available really empowers you, the listener, to be more informed about your own health. It helps you ask better questions and have more meaningful conversations with your doctors. So what does this all mean for you? Well, the next time you hear about stomach issues, or maybe even experience some yourself, perhaps you'll think beyond just, oh, it's probably heartburn. Maybe you'll consider that intricate ballet of bacteria, acid production, inflammation, and even your own immune system that could be happening inside. What surprising connection or piece of information really stands out to you from our deep dive today? What might you want to explore further?
That's a great point. Maybe consider how knowing about the different causes can shift your thinking about prevention. For instance, really understanding the potential impact of regularly taking NSAIDs versus the implications of having a bacterial infection like H. pylori, or recognizing the specific importance of checking vitamin B12 levels if you know you have an autoimmune condition like AMAC. It really does often come back to understanding the root cause rather than just masking the symptom.
That's a truly insightful thought to mull over. Finding the root cause. Fantastic. Well, that's all the time we have for this deep dive. Thank you so much for joining us.